So next we have chapter 16, cardiovascular regulation and integration. So again, like I told you guys, I'm going to be skipping through the chapter objectives. Please read through these just so you get familiar with what you need to know. But I won't really spend too much time going through these on our slideshows. So the first part that we're going to talk about is the intrinsic regulation of heart rate. So unlike other tissues, cardiac muscle maintains its own rhythm. So if we just left the heart to its own devices, it would beat at about 100 beats per minute. The SA node, or the sinoatrial node, is basically the heart's pacemaker. So it is going to be the structure that drives that regulatory heart rate that we typically see in people, which generally ranges from 60 to 100 beats per minute on average at rest. So here's the normal route for impulse transmission within the myocardium. So as you guys can see here, the sinoatrial node sits on top of the right atrium. And essentially what it does is it sends out these different signals to the left atrium as well as to its own atrium, the right atrium. And then that drives signals down to the AV node, and that AV node sends that signal down towards the Purkinje fibers, which eventually contract the ventricles. So you guys can kind of follow these little red arrows here, and you can see where that pulse transmission ends up going to. So next is the heart's electrical activity. So in the right atrium, the SA node spontaneously depolarizes and repolarizes. So basically what this means is it gets excited and then it relaxes. And that's simply nerve transmission. So we're not talking about any muscles in particular, but you're getting that nerve impulse that causes that excitation, and then you get that relaxation of that nerve impulse that causes that repolarization. So it spreads across the atrium back to the AV node, and then that AV node has a bit of a delay, so that you have that contraction of the atria first, followed by the contraction of the ventricles. So it needs to be that delay. If there wasn't, then everything would just contract at once and the blood wouldn't go where it needs to. So to continue on, we have the heart's electrical activity. So that AV node is going to pass its information to the AV bundle. So if you go back a couple slides, you'll see the AV bundle referenced in the picture. And this AV bundle is also called the bundle of His. The bundle of His transmits its impulse to the Purkinje fibers. The Purkinje fibers exist in the ventricles. Once that signal gets passed on to the ventricles, it causes that contraction of the ventricles. So this point here kind of summarizes these last couple slides. The transmission of the cardiac impulse flows in this direction. You have the sinoatrial node that passes on an impulse to the atria, causes a contraction. You have this impulse that passes on to the AV node, or the bundle of His, which passes that information onto the Purkinje fibers. And the Purkinje fibers exist in the ventricles that causes that ventricular contraction. And that allows the blood to get pushed out into the rest of the system. All right, so next is going to be the ECG, or electrocardiogram. So this is how we measure electrical activity in the body. So it's a composite record of the heart's electrical events during the cardiac cycle. So I'm sure you guys have all seen, the squiggly lines that kind of go up and down. If you've ever watched a medical show on TV, or if you guys have ever been exposed to an ECG, you definitely have seen a heart impulse. So we're going to talk more about ECG tracing. So again, these electrical events can monitor heart rate during physical activities and exercise stress testing. So if you guys kind of remember from lab 3, I had that computer system out and we attached it to your finger, and it kind of showed your heart rate up and down as we went through the exercise. That's not a super accurate ECG, but it gives you guys a sense of how heart rate reacts with each beat. So a valid ECG tracing requires proper electrode placement. So typically you might see people who have different pads. If you've ever been in a hospital or you've ever seen people who have the electrodes on their chest, this is typically an ECG monitor. So here's normal transmission of an electrical impulse through the myocardium. So we just talked about this a couple slides ago, but again, if you want a bit more of a visual to this, it shows you number 1 where that sinoatrial node is, and it follows all the way down to number 8, which is the Purkinje fibers in the ventricles. So this might be a nice little summary for you guys for a normal transmission um, of electrical impulse through the heart. So here are the different phases from a normal ECG. So if you haven't seen this before, this would kind of represent the heart's activity, electrical activity during one cycle. So we'll kind of just quickly go through this. I want you guys to know these details fairly well. There's some stuff in here that's a little bit more fluffy, and I'll try to let you guys know what that is. But basically, try to know what each portion of this impulse means, right? So first is the P wave, which generally represents the depolarization of both atria. Okay? Next is the QRS complex. So that usually indicates ventricular depolarization. Okay? There's a little bit of extra stuff in here that kind of maybe gives you a bit of an idea of why that's happening. But generally, I just want you to kind of know what you're looking for and what normal looks like as well. So just understand these bigger parts. So if we skip on to the T wave, it represents the repolarization of both ventricles. Okay, so we talked about that excitation that causes the depolarization, and then this is kind of that point of relaxation, where everything kind of just resets, and then you'll start this phase over again. So there are other terms that people like to look at if you do see an abnormal ECG. So sometimes, and this is not for you guys, but generally they'll look at like a PR interval, they'll look at the ST segment, and if that's a bit longer than typical, then maybe that is something that indicates some pathology. Or maybe they look at that QT interval, and if something looks a bit more abnormal there, then that might indicate pathology as well. So this is normal, and this is what you guys should know at this stage in time. But down the road, if you do go into health sciences, you might be looking at an ECG and seeing how it affects people with pathological conditions like heart failure or atrial fibrillation. So be aware of that going forward. So here are the ECG waves. We just talked about this on the last slide, but here's a little summary for you. You have that P wave that represents the depolarization of the atria before the atria contract. You have the QRS complex, which indicates ventricular depolarization. And then you have your T wave, which represents ventricular repolarization. So here's a bit of a summary for you just to indicate when each thing happens in that ECG wave. So we just talked about intrinsic regulation of heart rate and circulation. So those are all things within the heart that influence heart rate and circulation. Now we're going to talk about extrinsic regulators of the heart rate and circulation. So these are things from outside of the actual heart itself that are influencing our heart rate and circulation. So the first one is from nerves that supply the myocardium. So they will actually send these chemical messengers that accelerate the heart rate in anticipation of exercise. So just before you're about to participate in something that's a bit more strenuous, you might notice that you're starting to get that rush of adrenaline almost, right? So you're getting the heart rate's getting up a little bit. You are starting to feel like you're getting prepared to move. And you're not in this, dopey rest and digest state right at the moment. You really have to anticipate that movement, and your body will react accordingly through the nerves that supply the myocardium. The second part, or the second extrinsic regulator that we talk about here, is going to be the brain and the peripheral nervous system. Okay, so this comes out of the ventrolateral medulla. So to simplify that without overcomplicating, it comes from the brainstem. Okay, this is an important structure for you guys to be aware of, but more or less kind of understanding where that is. It's the front and outside of the brainstem. Okay, that regulates the heart's output of blood and the blood's preferential distribution to all body's tissues. Okay, so we have this reaction that's coming up from the brain and from our brainstem that's telling us, okay, the blood needs to go to this area, right? It needs to go to the muscles when we are doing exercise. It has a preferential distribution to the muscles when we do exercise. When we're resting and digesting, it has a preferential distribution to things like your organs and your digestive system. So just be aware that we have those nerves that influence things, and then we also have the brain and our brainstem that influences things as well. So here we go. This is a good summary of what we just talked about. So we have those higher brain centers, that's central command, that's your actual brain that's influencing things. And then here's the ventrolateral medulla, which again exists in the brainstem. And that will influence your heart rate and your circulation. Okay. Again, you also have these other receptors. So you have skeletal muscle ergoreceptors or mechanoreceptors that cause this reflex that's sent to the ventrolateral medulla. You have these cardiac mechanoreceptors. So this is all this neurological tissue we just talked about on the last slide that causes these baroreflexes and the cardiopulmonary reflexes. That gets sent to the ventrolateral medulla, and that causes an influence on that heart rate as well. So you have a lot of things that are influencing heart rate and this flow of blood to different areas, right? So you can see that influence ends up causing this chronotropic and ionotropic function of the heart. So chronotropic is an increase in rate in the heart, and ionotropic function is an increase in force of the heart. So when you start to do exercise, it sends this information to the ventrolateral medulla, and then it says to your heart, like, okay, I need to get going, I need to have more force, and I need to start beating faster. The muscles that you're using, it'll tell them to basically to vasodilate and start to work a little bit harder. And the ones that you're not using, they'll say, okay, we don't need this muscle right now. Okay, we're going to vasoconstrict. So we're going to kind of reduce blood flow to that area. And then things like your liver, your kidneys, anything like that, it's going to say, oh, I don't need that during exercise. I'm going to vasoconstrict and send less blood flow there. So more blood flow and more activity to the structures that require it, less blood flow, less activity to the structures that don't. So next is sympathetic and parasympathetic neural input. So these are the neural influences that override the myocardium's inherent rhythm. So we have these two systems that affect the way that our body reacts to exercise. And we'll talk about these a little bit more in depth in the next few slides. Okay, so here we have the distribution of sympathetic and parasympathetic nerve fibers within the myocardium. So as you guys know, parasympathetic is rest and digest, and sympathetic is fight or flight. So generally the parasympathetic nerve fibers originate in the higher centers of the brainstem and the brain. When the parasympathetic nerve fibers are passed to the heart, we generally see them more in the SA node and more in the atria. So when we talked about the intrinsic regulators of the heart, we talked about the SA node being the pacemaker. So if the heart was left to its own devices, as you know, it would beat at 100 beats per minute. Because the parasympathetic system, or the rest and digest system, is driving a lot of activity through this SA node, usually at rest, our heart rate is quite a bit lower than 100 beats per minute. So you can see that rest or digest system is decreasing our heart rate and helping us have that more resting heart rate of that 60, 70, 80 beats per minute that you would typically see. On the opposite end of things, we have the sympathetic system, or that fight or flight system, sending a lot of nerve fibers to our AV node, to our ventricles, a little bit to our SA node too, to help drive more blood flow through here. But when we're in that fight or flight state, or when we're in that heightened state, we need more blood flow. We need this heart to work harder. So these nerves need to come to these areas that allow us to pump more blood so that we can get more blood to our system, more oxygen to the tissues that we need, specifically muscle during exercise when we need it. So rest or digest drives down our heart rate a little bit. It's not going to as many areas. It's helping to drive this SA node to help us have that more relaxed and resting heart rate. And then we have that fight or flight system driving a lot more nervous tissue and a lot more neural activity to these areas that allow us to pump more blood when we need it. So here's the sympathetic influence. We just talked about this last slide, and I hope that's a good review and a good summary of what we're going to be talking about. But here's a bit of a written summary as well. These first couple points are the ones I want you to focus on. So the stimulation of the sympathetic cardioaccelerator nerves releases epinephrine and norepinephrine. So we know these as excitatory neurotransmitters, and those cause a chronotropic or ionotropic effect on the heart. Chronotropic essentially just means an increase in rate. So an increase in how often and how fast the heart is beating. And then ionotropic means force. So an increase in force and an increase in heart rate. So when we need that sympathetic response, we need the heart to be able to beat faster and with more force, so we pump more blood to the tissues that are needed. Next is the parasympathetic influence. Okay? So parasympathetic neurons release acetylcholine, and that delays the rate of sinus discharge to slow the heart rate. Okay? So acetylcholine drives things down, and on the sympathetic end of things, epinephrine and norepinephrine drive things up. When we get this slowing of heart rate, we get this thing called bradycardia. So bradycardia, brady means slow, cardia means heart. Okay? So slow heart rate results from a stimulation of the vagus nerve from the medulla. Okay? So if you guys go back a couple slides and you look at the picture and you say that parasympathetic system comes from the brainstem and the brain, well, the medulla is in the brainstem. So you know that this is where you get the stimulation of that parasympathetic system. And that vagus nerve is one of the most important ones that comes off of there. Parasympathetic stimulation excites some of the tissue and inhibits others. At the start of low to moderate intensity exercise, heart rate increases largely because we're not getting that drive from the parasympathetic system anymore. So when we start to exercise, it's not one or the other. We kind of have a combination of both, of sympathetic and parasympathetic. So when we start to exercise, it's mostly due to the parasympathetic kind of just shutting off a little bit at a time. And then the heart rate in strenuous exercise is increased by additional parasympathetic inhibition. So it's kind of this, it's not an on or off switch. It's kind of like a dimmer switch, right? So when you have the dimmer switch on all the way, well, that parasympathetic system is on full tilt and you're in that rest or digest period. As you start to do more exercise, that dimmer switch comes down all the way to the point where it's pretty much almost completely off, okay? So it's not just this on switch and off switch. So use that analogy when you're thinking about parasympathetic influence and its effect on heart rate and heart force as well. So here's the chemical, anatomic, and functional organization of these systems. So you guys can see here, we got the sympathetic on the left, we got parasympathetic on the right. You guys don't need to know all of these details. This is a lot, right? This is a ton of information just on its own. I want you guys to understand where the sympathetic system originates from, which is generally in the spinal cord, as we talked about. And the parasympathetic generally originates in the higher centers, kind of in the brain stem and the brain. And I just want you guys to have an understanding of how they influence the organs. You don't need to know all these details, okay? Just understand, what is the parasympathetic system doing to my overall system, right? To my eyes, to my heart, to my, to all my organs. And then vice versa, what does the sympathetic system do in general, right? No minor little details here. What does it do in general? So let's talk about central command. So this is the input from higher centers like the brain, the brainstem, etc. So the brain is obviously kind of like our motherboard of our body. It kind of tells our body what to do at different times. There's other things that influence things from the brain, but generally the brain is what controls most of our activity. So the most important point I want you guys to kind of take away in this slide is more or less this bolded point here. So I'm going to read this out to you and then I'll summarize it. So the heart rapidly turns on during exercise by decreasing parasympathetic inhibitory input and increasing stimulating input from central command. So to summarize this for you is essentially the heart will speed up during exercise by decreasing that rest or digest input, and then it will increase stimulating input from the brain. So it's going to get this input from the brain saying, I need to speed up. I'm doing exercise now. It's time for my heart rate to increase. And it's going to also say, I don't need the rest or digest anymore. I need to start sending my resources to the muscles that need to work to do exercise, and I need to divert blood and resources away from organs and other tissues that don't need blood at the moment. So here's the influence of central command on heart rate when movement begins. So you can see right off the bat here, we have this point of anticipation. So when we're anticipating that we're going to move, if it's just before a race, if it's just before we need to run away from something, we get this big spike in heart rate. It really jumps just in anticipation to it. And then as we start to run, it continues to increase. So we understand that, as our brain understands that we are about to go do something strenuous, it automatically increases our heart rate just to basically prepare your body to be able to do that. So that was kind of central input. Let's talk about peripheral input. So the cardiovascular center receives reflex sensory input from peripheral receptors in blood vessels, joints, and muscles. So the big thing from this slide here is to understand that we have these receptors. So it could be a chemoreceptor, it could be a mechanoreceptor within a muscle or its vasculature, so the vessels, and they monitor its own chemical and physical state. So based on what activity is happening at that muscle or at that vessel, it will modify its response. So either rest or digest response or fight or flight response to bring out the appropriate cardiovascular and respiratory responses to various intensities of physical activity. So when you're working really, really hard, your muscles also have those mechanoreceptors and those chemoreceptors, and your vessels have those mechanoreceptors and chemoreceptors that say, okay, I'm working harder now. I need more blood flow, so I need to drive more cardiovascular response and I need to drive more respiratory response. And I need to send a signal back up to the brain to tell my brain to do that. So that's a really dumbed down way of essentially summarizing the fact that we have this peripheral input sending information back to the brain. There's three mechanisms that continually assess the nature and intensity of exercise and however much muscle mass we need to have activated. So the first one is a reflex neural input from the mechanical deformation of type 3 afferents within active muscles. The second one's chemical stimulation of type 4 afferents within active muscles. And the third one's a feed-forward outflow from the motor areas of central command. So this is a very convoluted way of saying these points. Okay, so I think I'm going to try and summarize these the best I can for you. So when you see the word afferents, you're usually talking about nerves that are bringing a signal back up to the brain, right? Afferent is bringing it back up to the brain from a nerve. So when you get mechanical deformation of active muscles, so when you are working a muscle and it's changing shape and you're working it really hard, like let's say you're doing bicep curls and that bicep is shortening and lengthening and shortening and lengthening, you are going to get a mechanical deformation of that muscle and it's going to send a neural input or a neural response back up to the brain to tell it that it is changing shape. So when that muscle is going, flexing and relaxing and flexing and relaxing, it's going to send that signal up to the brain to say, hey, oh, there's a difference in activity. I might need to activate more muscle mass there. The second part is going to be the chemical stimulation within the active muscles. So we talked about the chemoreceptors and the mechanoreceptors. So if you want to think about point 1 as mechanoreceptors, point 2 is going to be your chemoreceptors. So there's different chemicals in there. We talked about norepinephrine and epinephrine and acetylcholine. Now, don't worry about which one it is. It doesn't matter at this point, but just know that there are chemoreceptors that recognize that there's more activity that is happening there, and there's these other things that are being released into our system, and it sends information through a nerve to say, hey, I'm activating more muscle. I need to have more muscle mass activated to perform this activity. And the third one is this feed-forward outflow from central command. So in your brain, you have a motor cortex. So when you start to activate muscle, it starts to fire that part of the motor cortex and say, hey, I need to start activating this. Like this part of my brain is turning on, so I am going to use that to send signal down to that muscle or down to those muscles that need more activity and more neural input. Okay, so if you have any questions about those three things, don't worry about what types of the afferents are. Just understand the main points that I'm trying to draw from these points here. Okay, so here's your three mechanisms for peripheral input. So this slide's kind of a bit more of a bonus information slide. I'm just going to go through the main point here, just so we're not wasting any time. So this first point is kind of the big one you want to take away here. There's a little bit of extra information here, but essentially what it's trying to say is those mechanoreceptors, they are going to provide information back to your brain or your central nervous system, and that's going to regulate blood flow and blood pressure during exercise. So I'm going to use a bicep curl as an example here. If you're going to go do a 5-pound bicep curl, well, you're not going to get a lot of deformation in the tissues, and those mechanoreceptors are not going to get fired very much. So you're going to understand that there's probably not going to be a huge increase in blood flow and blood pressure during exercise. But if I asked you to go and do a bicep curl with 100 pounds, there's going to be a lot of mechanoreceptor feedback because there's going to be a lot of deformation in that muscle. That's going to send that a lot of information back to the brain, and then that's going to regulate an increase in blood flow and blood pressure. Okay. The other information here is just that we have these pressure receptors or these baroreceptors in our aorta and our carotid sinus, and they can assess muscle activity in the heart. Okay, so they'll basically react to how much blood is getting pumped through those vessels, and when there's a lot of blood being pumped through the vessels, they know how to react to it. Okay. Carotid artery palpation. Don't expect you to know it. Just something for your information. If you put external pressure against the carotid artery, it can slow down your heart rate from a direct baroreceptor stimulation. So you guys have your carotid arteries in your neck. If you guys put your hands on those, you could actually slow down your heart rate a little bit because it has that pressure sensor there. Okay, that's really the only thing I want you to know. And then another thing to be aware of is that if you do have cardiovascular disease or any type of vascular disease, that can affect the carotid sinus sensitivity, and it can produce low heart rate values, right? So some people present with an elevated heart rate with certain pathologies. People who have vascular disease that affect the carotid sinus, they can actually get a blunted heart response because it's affecting that baroreceptor. So next we'll talk about the physical factors affecting blood flow. So the volume of flow in a vessel is related to two factors. It's related directly to the pressure gradient between two ends of the vessels, and then it's inversely related to the resistance encountered to fluid flow. So the first point here, the pressure gradient between two ends of the vessels. So pretend you have a straw, okay? If you have, let's pretend you have one person blowing into the straw on one end, but then the other person is not on the other. Well, the air is going to pass through no problem, right? But if you have both people blowing into the straw at the same time and there's pressure coming from both ends, well, that air is not going to pass through very well, right? It's going to be quite difficult. It's going to be very challenging for the two people who are trying to blow into that straw at the same time versus one person who's just blowing through that straw. Now, I wouldn't recommend doing that during COVID, obviously, but it gives you a great example of how that resistance from both sides and that pressure from both sides can affect the volume of air or the volume of flow that can happen through that vessel or through that straw. Now, the same is true for point number 2. So it's inversely related to the resistance encountered to fluid flow. So I'm sure you guys have had a milkshake at some point in your life. And I'm sure you guys have had something get stuck in your straw. So as you're trying to suck the milkshake through your straw and you have that resistance in there, you have that chunk of whatever stuck in your straw, well, it's not going to be very easy to get flow through that straw. So there's less flow when there's more resistance, and there's more flow or more milkshake that comes through the straw when you don't have that chunk in there. So just try and think about it that way when you are trying to work through these 2 points here. So there's 3 factors that determine resistance to blood flow. Okay, there's the blood thickness. So, you might have a milkshake that's really thick. It might be a lot harder to get through the straw, or it might be really kind of thin and soupy, and it will pass through the straw really easily. So viscosity is 1. The length of the tube is number 2. So if you have a really short straw, that milkshake's going to get to your mouth a lot faster than if you had a straw that was 10 feet long, right? You're going to have to be sucking on the straw for a long time before you get milkshake. And then 3 is the blood vessel radius. So how wide is this blood vessel, essentially? If you have a really tiny, super small straw and you try to suck milkshake through it, well, it's going to be pretty hard, and you're not going to get a lot of milkshake coming through the straw. But if you have a really wide straw, well, you're going to get a lot of milkshake that comes through that straw. So use that milkshake and the straw analogy when you're working through these last couple slides. I think that'll help you guys a lot. So this is Poiseuille's law. Don't worry if you don't know how to pronounce it. I don't even know if I'm pronouncing it correctly, but Poiseuille's law is expressing the relationship among the pressure differential, resistance, and flow. You do not need to know this calculation. So please don't spend your time trying to memorize that. But essentially, this is just a law that allows you to determine all of those factors we just talked about in the last couple slides and how they influence blood flow. So they talk about flow here and the pressure gradient and the vessel radius and the vessel length and the fluid viscosity. So if you're able to calculate all those things together, you can determine what the flow is. Again, you don't need to know all the details here. I just want you guys to know that this law is indicative of flow, and then understanding all of the factors that influence flow. So don't worry about this calculation, just know that these factors influence flow and know the name of this law. So here's the exercise effect on blood flow. We've already talked about these first 2 points. This is just a summary. If you're expending more energy, you need more blood flow, so that's going to impact the cardiovascular system and make it work harder, right? So the second point is during exercise, the arteries of active muscles will dilate, while other tissues that don't need blood will constrict. So this could be your digestive system. So these 2 points you guys already know from previous slides. There's 2 factors that contribute to reducing blood flow during in non-active tissues. Okay, so these tissues don't need to be on. So what's going to contribute to that? The first thing is going to be the increased fight or flight response. So we already know how that works, right? We know that that's going to drive the system to get our active muscles working more and have our less important structures like the digestive system not work, right? Or have less blood flow at least. The second part is going to be the local chemicals that directly stimulate vasoconstriction or vasoconstrictors. So if these systems like our digestive system that don't need to be on, we want them to vasoconstrict, right? We don't need the blood flow to them. So there's going to be chemicals that allow that to happen so that they're not getting more blood flow than they need. So factors within the active muscle. So skeletal muscle blood flow closely couples to metabolic demands. So if we know what metabolic demands means, right? If you need more energy, you're going to need more blood flow. So this regulation occurs from the interaction of vasoconstriction activity and locally derived vasoactive substances within the endothelium and red blood cells. I don't really care if you guys know this part, right? I want you to understand that when the skeletal muscle needs more energy, it's going to need more blood flow. So they're very closely related to each other. You already know that when a tissue gets more blood flow, it's going to be getting more of this vasodilation, this vasoactive component. And that's just derived from that endothelium and the red blood cells, right? So red blood cells provides oxygen. Oxygen is nutrients to the muscle. So let's not overcomplicate things too much here. This is just added information. At rest, 1 in 30 to 40 muscle capillaries remains open. Okay, so not super important, but you know that when the muscle starts to work, there's going to be a lot more of these capillaries that are open. So just understand that at rest, we don't have many open, but as we exercise, there will be more that do. Okay, so we just talked about how the capillaries stay closed at rest, most of them. And this slide is going to tell you about how when they open during exercise, what happens. Okay, so when we open the dormant capillaries in exercise, you get an increase in total muscle blood flow. That seems obvious, right? We open those precapillary sphincters, you get that blood flow coming through all of the capillaries, and that drives more blood flow into the muscle. It's also going to deliver a large blood volume with only a minimal increase in blood flow velocity. So you're not going to get this massive increase in speed of the blood flow because it's starting to give that flow a bunch of different areas to go into. You know, it's like having a bunch of different little creeks that blood can pass into. So you're not getting this huge flow through just one single vessel. And also, when it opens, it increases the effective surface for gas and nutrient exchange. So these capillaries are so small and so thin that this is where a lot of the gas exchange occurs. And we need that gas exchange to have a lot of different areas, especially during exercise. So it's just giving it more area to allow that to happen. Next we're going to talk about vasodilation. So vasodilation occurs from local factors related to tissue metabolism or energy demands that act directly on the smooth muscle bands of the small arterioles and the precapillary sphincters. So we literally just talked about this, right? So that vasodilation is basically going to happen for any one of these reasons here. I don't expect you guys to know every single one of these reasons, but I want you guys to be familiar with the fact that there's lots of influences to vasodilation, right? You could have decreased tissue oxygen and local increases in blood flow, right? So when you get that extra blood flow coming to the system, well, those sphincters need to open so that you can get more blood flow through the system. Temperature. When you're warmer, things are going to open up and vasodilate, right? Carbon dioxide. Okay, well, your system knows that it needs to flush out the carbon dioxide, so I need to open up more things so I can get more oxygen to the tissues. Acidity, right? Our blood usually has a pretty neutral pH. It gets more acidic. Okay, well, it needs to flush out that acidity, right? And usually acidity is associated with a higher carbon dioxide content. So just something to be aware of there. Adenosine, magnesium, potassium, nitric oxide, etc., right? I don't want you guys to know all this stuff. Here's a few examples for you. Just have a good understanding. There's lots of influences to it. So we just talked about vasodilation. I gave you guys a whole bunch of examples to that. But this is a molecule I want you to be aware of. It's nitric oxide. So nitric oxide serves as a signal molecule that dilates blood vessels and decreases vascular resistance. Okay? It's basically created by some chemical signals and also these mechanical stresses like the shearing stress and the vessel stretch of increased blood flow through the vessels themselves. So the vessel lumen and the endothelium are basically structures that create the walls of the vessels. And that's going to start the synthesis or the creation of nitric oxide. So kind of a complex way of saying it, but you got the chemical and mechanical receptors and that stress that's causing that nitric oxide creation. People who have cardiovascular heart disease, they have a decreased production of nitric oxide. And the reason this is important to know is because of angina pectoris. So we talked about this in chapter 15, but for you guys, an important thing to know is when you get decreased blood flow to the heart and you're having a decreased production of nitric oxide, sometimes you get that chest pain that we talked about in angina pectoris. So actually an intervention that people use for angina pectoris is a nitric oxide spray. So they actually get a spray that they can spray into their mouth, and it'll actually reduce the amount of chest pain they have because it'll open up the blood flow to their heart, and it'll actually dilate the blood vessels. So kind of a practical intervention for you guys to understand. So here's nitric oxide regulation of local blood flow. So you can see here's the nitric oxide being created, and then here's the vasodilation that occurs. You guys can read through this a little bit, just to kind of understand the process of how that works, but just more of a visual for you guys here. So here's the integrative response during physical activity. So the command center above the medullary region, so this is up in the brain and the brainstem, initiates cardiovascular changes before and during movement. So you have that anticipatory reaction to exercise. Heart rate and myocardial contractility increase from a feed-forward input from central command, which depresses the parasympathetic activation. So we talked about that dimmer switch and how as we start to do exercise, that dimmer switch gets turned down more and more and more from that parasympathetic system. There's predictable changes in the regional blood flow that occur in proportion to exercise intensity. So there are certain regions that are going to get more blood flow when you're doing more intense exercises, and there's going to be certain areas that get less blood flow when you're doing more intense exercises, like your digestive system. The modulation of dilation and constriction optimizes blood flow to needed areas while maintaining blood pressure. Okay, so that's what we talked about in chapter 15, where your arteries will stretch and they'll accommodate for that extra blood flow so that you're not getting a massive spike in blood pressure, and it can be regulated well as you continue to exercise more intensely. Local metabolic factors act directly to dilate resistance vessels in active muscle. So you have these things that essentially your energy demands are going to determine how much your vessels will dilate. Vasodilation reduces peripheral resistance, so you get greater blood flow to active areas. And then vascular constriction in inactive tissues maintains adequate perfusion within the active muscle while maintaining the blood supply to satisfy local metabolic demands of inactive areas. So basically, areas that don't need blood flow, they get less blood flow, but they just get enough so they can continue to survive and exist as needed. So you might get less blood flow to your digestive system, but it's not going to be so much that the tissues in your digestive system are going to die because they're not getting enough oxygen and blood flow. So now we're going to talk about a bit more pathological related exercise. So this is exercise after a heart transplant. Usually people who have had a heart transplant, they have a prolonged VO2 kinetics, they have impaired exercise capacity, and they have diminished physiologic and hemodynamic function. So a more simplistic way of saying this is they don't have the capacity to reach the levels of a healthy individual. They don't have the energy to exercise as long as a healthy individual. They don't have that, that volume of oxygen capacity and the ability to kind of adapt to higher levels of exercise. So their VO2 max, for example, would be decreased. And they also have these diminished physiologic and hemodynamic functions. So basically their heart is not pumping as efficiently as someone who has their own heart and someone who is a healthy individual as well. So they can still perform intense exercise and they can still do some pretty good things performance-wise, but they're usually only going to reach the level of a moderately trained healthy subject. A post-transplant patient is going to show no stroke volume plateau during graded exercise. So you're just going to see this graded increase in stroke volume. And that's because of this Frank-Starling mechanism, and we're going to talk about that a little bit more. Also, exercise response does not improve over post-surgery period, but adaptations exert no meaningful effect on submaximal or peak VO2. So they basically get a better response to exercise. Like they might not feel as tired, or they get a bit more accustomed to doing the exercise that they're doing, but it's actually not creating a huge effect on their VO2. So here's a heart rate response to graded exercise before and after a heart transplant. So before they have the transplant, you can see their heart rate just increases very linearly with exercise intensity and then drops off with recovery. But after a transplant, what you typically see is it levels out because they don't have the capacity to get their heart rate super elevated, and then you don't see this really drop off of values during recovery. So heart rate will stay quite steady for quite a long time, and eventually it'll start to come back down, but overall you start to see this trend a bit more. So here's the long-term heart transplant effects on aerobic functional capacity. So this first table, or this first graph, is the VO2 peak. Okay, so what's their capacity to change in their VO2 over the course of 11 months? Well, it's not a lot, right? You can see they improved a little bit, had a bit of a nice reaction to it, but overall, not a huge change in averages here. You see some people who had kind of a gradual increase, some people improved quite a bit, and some people who didn't change at all. You can see some of these lines are very, very level, so they had almost no change. Some people actually decreased. So you can see that there's quite a large variability, but overall the change is not significant in VO2. When we talk about VO2 peak and percent improvement over time, they tracked people over a lengthy period of time. Looks like they tracked for at least 9 years here. And you can see that really it didn't change at all, right? So their percent improvement was pretty insignificant. And their actual VO2 max itself, or their VO2 peak, was very steady throughout the course of time. So you're not going to see these huge increases in VO2 max like you might in a very trained athlete who might see a lot of gains over time. They're going to stay very stagnant over the course of time after their transplant. So here's a continuation of the long-term effects of a heart transplant. So you can see in this graph here, or this table, we have our normal population that's indicated in blue. So these top ends here. We have the after cardiac transplant in the green, and then we have the before cardiac transplant in the purple. So you can see the normal population is going to have quite a bit higher VO2 at this particular age than someone who is after a cardiac transplant. And then you can see people who have had a cardiac transplant, they do better than people who are before a cardiac transplant. So you got to think when people are needing a heart transplant, their heart function is pretty significantly diminished. So you're not expecting them to have very high VO2 levels, and that just worsens over the course of our lifetime, right? So we do see improvements after they've had that transplant, but they'll never quite be at the levels of a normal population for obvious reasons. So just a graph to indicate that. Then these are the summary slides. I'll let you guys work through these. And that is the end of chapter 16. Bit of a lengthy one because we went through some examples and we went through some analogies in this one. But hopefully you guys took a lot away from this lecture, and then we will see you for chapter 17.